So I'll be presenting the updated analysis of CheckMate 914, which was essentially a phase 3 trial comparing Nivolumab Ipilimumab in combination versus placebo for the adjuvant in the adjuvant setting for RCC post nephrectomy. Initially, it was presented in 2022 in the ESMO. Latest update was in ASCO 2024. So why it was done? So just as newer therapies, such as earlier cytokines were used, then TKIs were used, with not much benefit in the adjuvant setting. Pembrolizumab came and has, gotten approval due to its PFS and most recently OS benefit also in localized RCC, who do have a high chance of relapse, especially 25 to 40% in the higher risk localized RCC. So this trial was done to look into Nivo Ipilimumab if this combination improved the outcome. So this was a double-blinded phase 3 study between 2017 and 21. Patients who had undergone open or radical nephrectomy and who had no evidence of disease at all were included in the study. Most patients had clear cell histology. Around 5% had sarcomatoid features. They didn't take other histologies into consideration in this trial. So patients who had a tumor of at least more than 7 centimeter who were grade 3 or 4, more than 10 centimeter and above, that is PT 2B, 3 and 4 irrespective of grade. Patients who had nodal positive disease were included in the trial. Patients initially were randomized into Nivo Ipilimumab arm versus placebo versus Nivolumab alone. The patients received treatment for a duration of only 6 months as against other trials for a year, which received treatment for a year. The median follow-up was 27 months. Primary endpoint was disease-free survival by the blinded central reviewer. Secondary endpoints were DFS for Nivo Ipilimumab. So primary endpoint was for Nivolumab alone. Other secondary endpoints were overall survival and safety. So the treatment period was 24 weeks. It was extended up to 36 to take into delays and interruptions also. So later, this entire trial was amended into Part A and Part B. Part B was separately taken into consideration to see if Nivolumab alone would how it would fare against placebo, and to look into how each component would contribute. So this was the ESMO 2022 initial Part A trial data which came in, which looked at DFS for these patients of Nivo IP versus placebo. So here the median age was 58 years. Most patients were white people, and only 5% of these patients had sarcomatoid variant. Most patients had a P3 disease, and most patients had grade 3 or grade 2 disease. So the primary endpoint of DFS at a follow-up of 37 months was not met in this trial. The disease-free survival, the hazard ratio was only 0.92. And at 2 years, it was 76% versus 74%. So the only subset which seemed to have some benefit was the sarcomatoid subset. But again, the number of patients were just 4 as compared to the rest of the patients in this particular study. The safety analysis showed that because of the combination, the grade 3 or higher toxicities were almost in 1 in 3 patients, and discontinuation rates also were pretty high. Overall survival at that particular point could not be analyzed as the number of events had not been reached to analyze. So overall, Arm A showed that there was no benefit of adding Nivo Ipilimumab even to suspected higher risk RCC in the adjuvant setting. And there was the safety results were consistent with previous studies, and so overall survival data had not matured yet. So this was a recent update of the trial, the Part B, which was present in ASCO 2024. Here trials which were not here patients not included in the previous trial. So Nivolumab versus placebo alone in a 2:1 randomization were included in this study. And the median follow-up was for 27 months. So here again, the age group was similar to the previous study where 59 was the median age group. Most patients had P3, that is 4 out of 5 patients had P3 disease. And most patients either had non-evaluable or less than 1% PDL1. You can see only 11% had a PDL1 expression of more than 1%. So the disease-free survival in this particular study also more or less as expected, because the combination arm didn't work either here. The hazard ratio was 0.87 and not significant. They did conclude through the subset analysis that the subgroup analysis that probably patients who had sarcomatoid variants, who had a higher PDL1 and who were anemic seemed to do better. Of course, you can see that the number of patients in this particular subgroups are very low. So most patients received the median duration of treatment was 5.1 months. The discontinuation arms were much higher in the Nivo Ipilimumab compared to Nivolumab. Grade 3 and higher side toxicities also were higher in the combination arm. So because of the outcomes as such, contribution of each components were not relevant. So both these studies, both the parts essentially did not show any DFS benefit. Even the health-related quality of life scales did not vary between the placebo arm and the Nivolumab significantly. So to conclude, the DFS was not met in this particular trial. Safety was consistent with the previous analysis, and probably the only subgroups, those with higher PD-L1 and sarcomatoid features and who were anemic, seem to benefit from adjuvant immunotherapy, either single agent Nivo or Nivo Ipilimumab combination. Now, just to give you an idea about what trials we have so far, this is CheckMate 914 that I presented. The only positive trial we have so far is the Keynote 564 trial, which used 12 months of pembrolizumab against 6 months of nivolumab. But this has shown an a PFS benefit in the updated analysis. It's still persistent, and it has also shown an overall survival benefit. The other trials such as atezolizumab and perioperative nivolumab, the PROSPER trials have essentially failed. Now, why pembrolizumab arm actually succeeded versus others, we're not sure. But pembrolizumab included exclusively patients with clear cell RCC. Patients also had M1, no evidence of disease. So probably these patients have a different biology. The sarcomatoid, the percentage of patients with sarcomatoid histology were higher. Patients with PD-L1 were higher, 74% as compared to much lesser. Probably that's why. And probably it makes a difference to have a PDN versus PD-L1. Also, the duration of treatment would matter. Thank you.